Hello, everybody, and we welcome you to our WPA Conflict Management and Conflict Resolution Sections webinar just before Christmas. Here we have a wonderful colleague of ours, Dr. Artin, a board certified psychiatrist from Canada, working also in USA and United Kingdom. And he is going to deliver a wonderful and a great lecture today for us entitled Ethics, Human Rights, and Existentialism in Conflict Management. So, Artin, thank you very much for being here, and please, the floor is yours.
Thank you, Ruta, for the nice presentation. I really hope I can keep it to the greatness you presented the speech. So I'm Artin Madanian, a psychiatrist based in Washington, D.C., practicing in Canada, U.S., and also registered with GMC in the U.K. Today, I'm going to talk about, as Ruta said, ethics, human rights, existentialism in conflict management. The conflict management part actually is not area that is of my specialty, but I try to connect all this with conflict management. I have nothing to disclose. I work as an independent psychiatrist, as I mentioned. So what I'm going to do today is first I try my best to do a definition of conflict resolution and conflict management, and then Dr. Swardi and Dr. Ruta, who are here and are expert, and Dr. Victor Sanchez also, they're expert in conflict management. They can correct me if I was not complete about conflict management. Then I would like to do a summary of human rights and how human rights implicate in conflict management, conflict resolution, and clarify ethics from my point of view in conflict management, conflict resolution, and and also another area that I'm interested in and I've been working in the last couple of years is existentialism, and I try to link it a little bit with conflict management. And if we have time, eventually I want to talk a little bit about a new method of therapy and psychiatric care that I'm trying to introduce to psychiatry. So first, what is conflict management and resolution? So as in my understanding, the term conflict comes from the fact that there are two sides that they don't agree on one thing, and this disagreement can cause sort of humanitarian issue. It can be a war, it can be sanctions, it can be any kind of problem that causes humanitarian issues. So then for conflict management and resolution, a group of people that can be psychiatrists or health professionals try to mitigate the consequences of this conflict. So they can do some informal, formal processes to reach a peaceful solution, negotiation, mediation, conciliation, arbitration, or facilitation. But also more than that, there's one political aspect of conflict resolution, but there's one healthcare aspect of conflict resolution. So whenever there's a humanitarian crisis, there are healthcare needs in conflict. So as psychiatrists or mental health professionals, we need to have a strategy how to help people who are in these conflict situations in terms of their healthcare needs and mental health care needs. And also, I think one of the goals of conflict management and resolution section of WPA is to empower psychiatrists to be able to create and share ideas on better mental health management in conflict areas and integration of mental health across all aspects of humanitarian emergencies. Now, if you were in WPA, last WPA conference in Prague, Dr. Fahmi Hanna from WHO made a great presentation about role of psychiatrists in humanitarian emergencies. I just borrowed a couple of slides from his presentation. So this is about what role psychiatrists can play in humanitarian emergencies. I say psychiatrists, it can be any mental health professionals, psychologists or counselors. So they can be program and humanitarian response advisor, trainers, supervisors, reference point coordinator, clinical service provider. So it's not only clinical service provision that is the main thing during a humanitarian crisis. Facilitating multidisciplinary team training, and a lot of other roles. WHO has a lot of guidelines. One of them is psychological first aid, and the recommendation of WHO in humanitarian crisis is to provide psychological first aid. This is one of the guides that Dr. Hannah presented. And then for psychiatrists or mental health professionals who are in a humanitarian situation and want to promote mental health well-being, they should follow a pyramid which is similar to Maslow pyramid of human needs. And this pyramid shows what approaches you should take. The first thing you should do is basic services. Even you're a psychiatrist specialized in trauma or PTSD, when you are in a humanitarian setting, the basic needs, food and water and shelter and safe situation, these are the main things you should consider. Then you should think about how to reconcile people, communities, family support, non-specialized services, and eventually, if there is room, you can provide your specialized service. Now, some words about human rights, which is close to my heart, and I've been doing some work in that area. So, definition of human rights are rights and freedom to which all individuals are entitled, regardless of their nationality, ethnicity, gender, religion. So, if you remove all labels and you say that everybody is entitled to a set of essential and inherent rights, and they have it, you cannot remove it from them, and you do not bestow them to them. They are born with it, technically. Uh, uh, there's a nice expression that they say that even if people are not born equal, they are born with the same set of rights. If as a neuroscientist you believe that people are born differently with different level of cognitive function or memory or intellect or whatever, remove the geographical area, they're forced to be born in an area, but the rights they are born with, that's equal. You can categorize human rights into civil political right, economic, social, cultural rights. I don't want to go too much into detail of each one, but historically, going back to human rights, I like to talk about that because I'm of Persian origin, and just not long time ago, uh, United Nations recognized Cyrus Cylinder as the first charter of human rights in history, and that was 500 BC. So before Cyrus Cylinder, Hammurabi in his law also talk about human rights. And one thing we need to consider is if you look at Cyrus Cylinder or Hammurabi Code of Ethics or Roman law and rights, compare them to current law, they are considered total discrimination and not human rights. But we should look at documents in the context of when they come from. When Hammurabi wrote his code, you could kill a slave without any consequences. And then Hammurabi said that, okay, if you kill a slave, you should pay I don't know, 10 coins as a consequence. So that was giving some right to slaves. And then Cyrus released all the slaves, let freedom of religion, and come to the Middle Ages. Magna Carta in the UK was literally the first the first human rights, the first constitution, or if you cannot, if you don't want to call it constitution, the first set of laws and rules governing a country that included human rights in it. And then the modern foundation of human rights, U.S. Declaration of Independence and U.S. United States Constitution is actually the first modern Charter of Human Rights that includes a lot of rights for citizen and citizenship and pursuit of happiness and liberty. Then French Revolution, abolition of slavery in UK and US. And eventually we had the Second World War, during which we had a lot of human rights violations documented in the history. I don't want to say that Second World War was the worst human rights nightmare of history of human being. Definitely we had worse than that previously in time. But the Second World War was the worst documented human rights violation. So when the war finished, the countries sat and they said that let's make a rule that we don't want to violate these basic rights. So they made UN Universal Declaration of Human Rights that includes a lot of rights like equality, no discrimination, life, liberty, no slavery. But still, there are a lot of things not included in UN Declaration of Human Rights, like right to work and employment, food and shelter, affordable education, affordable healthcare, and the most controversial right to dignified death, which some countries now they are working on it. Now, after UN Declaration of Human Rights, they recognized that they talked about rights of people, but people with disabilities are left out because there's no mention that people with disabilities have equal rights to people without disabilities. So in 2006 to 2008, UN made a Convention on Rights of Persons with Disabilities, CRPD. Majority of countries have signed CRPD, but they haven't applied the rules of CRPD in their country. And to my understanding, I might be wrong, but I remember that the United States is one of the countries that has not signed CRPD yet. Canada has signed CRPD, but doesn't apply CRPD in the mental health law. So CRPD has about 50 articles, and the function is reform of mental health to include human rights in mental health acts to include human rights. The main articles are about accessibility, recognition, liberty, freedom of inhuman treatment, protecting integrity of person, independence, and right to employment. Then WHO, based on CRPD, created a set of packages of training and guidance materials in order to build capacity for mental health providers and mental health care in humanitarian settings that includes all the rights and all the rules of CRPD, and they are called WHO Quality Rights. I recommend that you have a look at those. Now, talking about human rights, United Nations Charter of Human Rights, and then CRPD, what are human rights that are applicable in conflict resolution? So number one, accessibility of treatment. So everyone, regardless of the situation or setting, they should have access to mental health care services. So in conflict situations, there should be also inclusion of mental health services and provision. Second thing is informed consent. If somebody is in a crisis or a humanitarian setting or in a war, it doesn't, or in a, I don't know, a dire situation, it doesn't mean that they don't need to consent to the care or to the service that we provide. Even in humanitarian crises and conflict situation, we need to respect dignity and we need to be non-discriminative towards people with mental health conditions. And we should be able to provide the least restrictive environment, even in humanitarian crisis settings. So treatment and care should be provided in least restrictive setting. Avoid unnecessary use of coercion. I put unnecessary in parentheses because it depends if you're a clinician or a human rights advocate. Human rights advocates, they say avoid any use of coercion. It's not necessary. It's not evidence-based, and it doesn't do good. But as clinicians, we know that sometimes it's necessary, and it's inevitable with the level of services that we have at the moment. And finally, privacy and confidentiality respecting confidentiality and privacy. So second part is about ethics in conflict management. The most important thing about ethics that I want you to remember from my presentation today is impartiality. So if you want to work in a conflict situation, in a war, in a crisis, you should be impartial. And impartiality means that you don't have any favoritism, you don't have any bias, or it's impossible not to have bias, but you're aware of your own biases towards parties or issues that is happening in a conflict situation. So as a mediator, you should be impartial. But remember, impartiality doesn't mean neutrality. So if you see human rights violation, if you see unethical behavior from one party, you are not neutral. You are not supposed to be silent. You can talk, you can speak out, you can act, but you are impartial towards labels. You're not neutral towards ethical violation or human rights violation. And now I want to talk quickly about existentialism. You know, I can talk hours and I have many slides because this is the most interesting area for me. But briefly about existentialism in conflict management, you know, usually we don't think and talk about big questions of life, identity, and existence. But crisis situations is one area that people start to think about their identity, who they are. What is my place in the world? Why me? Why here? And it's kind of the crisis is an identity threat. It's a violation of dignity. So when such situation happens, people start to think about these big existential questions. So one thing that is important for mental health professional is to consider the encounter first stance. It means that you are not there to resolve these issues. You are not there to go deeply into the meaning of these questions or the problem, but you are just there to sit, to talk with the person and to listen to what they have to say and what's their worries. So you acknowledge their concerns before doing the problem solving. You try to help them with creating some sort of value or meaning in the crisis or find their path in life. And you try to help them to become the author of their own life, but you don't try to solve the problem. You know, maybe I later talk about it, but it reminds me of Martin Buber's, you know, philosophy of I-thou relationship versus I-it relationship. He believes that majority of relationships are I-it, and I think majority of healthcare relationships are I-it. I know the answer. You are here to get help from me, and it's not helpful. It's not going to help the patient, especially in mental health settings. But I-thou relationship is that we are two travelers, two human beings. We don't know the answer. I'm here to listen, and maybe I can help, or maybe I can help you find the answer yourself. So that is the way to help. Now, quickly about background of existentialism, you know, probably starts from Schopenhauer when he talks about will to survival, that the biggest power behind everything is the will to survive. And then Kierkegaard, who is known as father of existentialism, is the first person who talked about choice and that you can if you are religious, if you believe in God, it's your choice. You choose to believe in God. There's no other evidence to prove it. And then Friedrich Nietzsche, who has a lot of meat and content of existentialism in his writings. His criticism of religion, he's a critic of religion and traditional values, and he talks about human will to power, search for meaning, the idea of Übermensch, and the idea of amor fati, which is radical acceptance of your life and participation in life. Then we have Jean-Paul Sartre, which talks about you exist, then you will have a meaning in life. And we have Simone de Beauvoir, who talked about women's liberation, and Martin Heidegger, who brought the idea of authenticity. And he has one nice idea that science does not think. That means that science has become a religion of our time. And then the idea of absurdity and the dialogical I-DA relationship from Martin Buber that I talked about. There are also some people who don't necessarily consider themselves as existentialists, but they have some ideas in existentialism. Now, existentialism became as a psychotherapy practice by the work of Binswanger, who talked about existential analysis of being, and then Rollo May wrote the book Psychology of Existence. Viktor Frankl wrote Will to Meaning and Logotherapy. And then finally, Irving Yalom, which is still alive, our contemporary psychiatrist, wrote about givens of existence and existential psychotherapy. So talking about death, mortality, freedom, choice and responsibility, isolation and connectedness, and meaning and purpose in life. Now, in mental health and conflict settings, there are some notions of existentialism which are important. Existential anxiety and angst, when you're aware of meaninglessness of life and the problems, alienation and isolation, despair, imagine you are in a war, definitely you will feel desperate. Death and mortality and finitude, you see finitude in front of your eyes when you are in a conflict situation. And then the absurdity of life and revolt and rebellion. So there are some common concepts of human rights with existentialism: capacity for self-awareness and growth, freedom and responsibility, authenticity. So these are all in both human rights and existentialism. So I thought, now I talk about this just a few minutes and then we can stop for questions for the last 5 minutes of the talk. I thought that we can introduce a new framework for mental health in all settings, including conflict management settings. And that is right-based existential psychiatry, which is an approach which shares common grounds of existential philosophy and human rights. It integrates both principles to providing a therapeutic approach that offers a space of respect and upholding right of people. It's especially helpful for people who feel alienated from traditional mental health services. It emphasizes on dignity, autonomy, authenticity, capacity, and rights, addressing existential concerns, as I said, isolation, meaning, death, choice, responsibility, right to choose, finding your place in wars, especially when you are in a crisis setting. So in essence, right-based existential psychiatry aims to honor human rights and existential concerns of individuals, fostering a therapeutic relationship that is both ethically grounded and attuned to the deeper dimensions of human experience. It moves beyond just treating symptoms, emphasizing the importance of people's right to self-determination and the search for meaning. Now, if we accept right-based existential psychiatry as a framework, then we need a therapy model Carl Jung once said that when a doctor tells me that he adheres strictly to this or that method, I have doubts about his therapeutic effect. I treat every patient as individually as possible, which speaks to the individualized care which we are talking about. So I thought about introducing an individualized model of eclectic psychotherapy. I named it myself Dynamic Eclectic Existential Psychopharmacotherapy, Deep Therapy. I don't want to go too much into details of that. We don't have time, and I want to finish in 5 minutes to leave some time for questions. I had a alert that we have 10 minutes left from the Zoom meeting. So deep therapy is a transdiagnostic, eclectic, patient-centered approach that embodies the framework of right-based existential psychotherapy. It's to offer a structure to deliver personalized, ethically grounded, right-based, culturally sensitive, and existentially attuned care. It incorporates 7 modules. I briefly talk about them in the next slide. And each of the modules are grounded in already proven evidence-based practices. But the combination of these 7 elements is a shared commitment to respect patients' narrative, choice, and meaning. And this is the novelty of this model, that you combine all these 7. So the 7 modules are acceptance, rooted in DBT, acceptance and commitment therapy, and amor fati, radical acceptance of Friedrich Nietzsche. Behavioral change, if you see, it's A, B, C, D, E, F, G, the 7 modules. So B is for behavioral change, and it's rooted in the behavioral therapy, behavioral activation, behavioral change. And it's all of these modules are existentially approached. So behavioral change is not prescriptive. It is more explorative with the client, with the patient, to see how we can change the behavior together. Cognitive restructuring, rooted in CBT, mostly looking at how people, what are the core beliefs of people about life, and how we can help them explore it more. Again, not prescriptive. We are not going to change. We are not going to label thoughts helpful, unhelpful, positive, or negative. We explore in deep therapy, but we try to restructure thoughts. And then dynamic analysis, looking at the psychodynamic and relationship. The most focus in dynamic analysis in deep therapy is the relationship, not in transference, counter-transference stance of psychoanalytical therapy, but mostly in I-thou relationship stance of existential therapy. And then existential exploration, looking at death, mortality, meaning of life, choice and responsibility. And I can give another lecture probably talking just about existential exploration. And then as a psychiatrist, focused pharmacotherapy, evidence-based, guideline-based, minimum dosage, not polypharmacy treatment of psychiatric conditions. And then eventually grounding techniques, which are used at the time of the best techniques that can be used at the time of crisis to foster a sense of stability. They are not linear. They can be used, these 7 modules, A, B, C, D, E, F, they can be used depending on the session and the situation. Now, I don't want to go into details of each module because we don't have time. These are some examples of existential exploration techniques. Here and now processing, existential confrontation, mortality reflection, and Socratic dialogue, symbolic letter writing, and then so on and so forth, and focused pharmacotherapy. So thank you for your attention, and I leave 5 more minutes of our time for questions, if anybody has any questions. And I think I'm going to stop recording before the questions, if everybody agrees.
Thank you very much, Dr. Artin. It was a great presentation. We want more, so we'll have you again at some point. And it's great to hear about it's not only a nice reflection, but also bringing this framework, bringing this integration. Maybe just in 1 or 2 minutes, but because we were talking about human rights, and as you have discussed also in the past, like we psychiatrists, we have been like the bad people of the movie, right? And in part, we have deserved it. But how this framework and other initiatives can make us become, especially us early career psychiatrists, become actual leaders and advocates of human rights and have a new role, a new deserved role in the world that is relevant. Thank you.
Yeah, thank you, Victor. I kept this part in the recording, so your son will be also in our recording of WPA.